Alrighty, everyone, can you see my screen and hear me okay?
Yes.
Yes. Wonderful. Well, like I had said earlier, my name is Kenny Bargi, and I'm a clinical pharmacist with Five Rivers Health Centers in Dayton, Ohio. Previously, I was a hepatology pharmacist for the Ohio Health Comprehensive Liver Program at Riverside in Columbus. When I was with Riverside, I led a hepatitis C treatment protocol led by pharmacists. And in the span of about 2 years that I was with them, I treated a little over 500 patients. So today we'll be discussing how to screen, treat, and look at pharmacologic considerations for patients with hepatitis C. Hopefully, share some of the insights that I learned along the way as well. There we go. Today, there are five learning objectives that are listed here for you. We'll look to review the epidemiology, etiology, and pathophys of hepatitis C infections. We'll also differentiate between patients who are appropriate to treat in a community setting versus those that require additional referral, whether it be to hepatology, gastroenterology, or infectious disease. We'll review the AASLD IDSA guideline recommendations for hepatitis C treatment. We'll also assess the primary literature surrounding the two main medications that are used in the community setting, those being Epclusa and Mavorite. And then lastly, we'll discuss the drug acquisition process and follow-up needs. So I apologize, some of this data is a little bit out of date compared to what's currently available. But according to the CDC, the incidence in 2019 was about 57,500 cases per year, whereas the prevalence was about 2.4 million patients. This year's annual report from the CDC is showing that these have unfortunately trended upward, and the prevalence is looking closer to about 4 million patients. Some of this trend is due to lack of treaters in the community setting, lack of patient access, as well as socioeconomic barriers, which we'll get into why those are important a little bit later on. Here in the United States, the most common genotypes by far are 1A, followed closely by 1B, 2, and 3. There are a total of 6 genotypes with several various subtypes. Genotypes were historically a bit more important as our medications were genotype specific. However, the two main medications that we use nowadays are pangenotypic. According to the World Health Organization, there's an incidence rate of about 1.5 million cases of hepatitis C worldwide per year and a prevalence of about 58 million patients, resulting in a mortality back in 2019 of about 290,000. This led the World Health Organization to create a roadmap for elimination. That roadmap was first set out in 2016 and had a target goal of complete elimination by 2030. Unfortunately, like I said earlier, based on our prevalence, we have not been able to meet that targeted elimination thus far. So, what exactly is hepatitis C? Well, it is a single stranded RNA virus that you transmit through blood contact. So, it is a bloodborne virus. Similar to most viral replication processes, there's the attachment, uptake, fusion, translation, replication, assembly, and release of the virus. The main focal point of this etiology will ultimately be the translation. Because it is a single-stranded RNA virus, that RNA will be translated to several structural and non-structural proteins, which those non-structural proteins serve as our drug targets against hepatitis C. And we'll get into that when we look at the mechanism of action for the drugs. There are several extrahepatic manifestations that can come along with hepatitis C. The most notable one would be dermatologic changes, especially with porphyria cutanea tarda. You can also have hematologic changes through mixed cryoglobulinemia, and then renal changes as well. So, as a provider within the community or addiction medicine setting, what is really your role in hepatitis C management? Well, the most important thing that you could argue is that we should be screening patients appropriately. We want to then manage their risk factors to prevent reinfection or prevent the spread to others. You want to differentiate between those that can be treated safely within the community setting versus those that require more specialized care. And if they do require specialized care, making sure that you refer them out and link them appropriately. In 2020, the CDC released updated recommendations for screening. Prior to 2020, the recommendations surrounding screening were largely population driven. They included baby boomer populations, should have been screened at least one time, and then anyone with ongoing risk factors. Well, starting in 2020, that really changed and the script was flipped. Now it's recommended that anyone 18 years of age or older should be screened at least one time for hepatitis C. If you're a patient who's less than 18 years of age and you have associated circumstances or risk factors for hepatitis C, you can absolutely be screened earlier. Situations like this, I would assume, are vertical transmission, where potentially transmitted from mother to child. You could have adolescent drug use as well, that might start in their teen years. And then one-time screening is also recommended for any prenatal assessment with each and every pregnancy, similar to what we do with hepatitis B before pregnancy. Repeat testing is done on an annual basis for those who have ongoing IV drug misuse. Also annually for men who have sex with men, especially those that are HIV infected or taking HIV PrEP. You can then have periodic and repeat testing done for all persons with continued associated circumstances, so truly risk factor based at that point. So we had mentioned the risk factors a couple times, so what really are those? By far the most common risk factor here in the United States now is intravenous drug misuse. There are some reports that show about 67 or more percent of all patients with hepatitis C now have it as a result of IV drug misuse, whether it be current or former. There's actually a study that also showed that if you have ongoing IV drug misuse and you're actively infected with hepatitis C, within the first 3 years of your diagnosis, you'll infect 20 other people. That led to some of the guideline changes that we'll talk about a little bit later on. But regardless of if you have active use or not, you should be able to pursue hepatitis C treatment because of the risk of infecting others. Outside of IV drug misuse, you also have intranasal drug use along with glass crack pipes, especially in the African American population. If you had receipt of blood products prior to 1992 or clotting factor concentrates prior to 1987, that's because blood banks started to assess for the hepatitis C antibody right around the time of 1992 when accepting blood products for transfusion purposes. You can also have a risk factor of long-term hemodialysis because of the frequent instrumentation. Healthcare needle stick injuries, you can have vertical transmission or perinatal transmission. History of incarceration. If you look at the top two leading risk factors for hepatitis C, they can lend themselves for people to become incarcerated. And so the percentage of the population who is incarcerated with hepatitis C is higher than that of the percentage of the general population with hep C. You're also living in closer quarters, sharing products, and you can have the potential for tattoos or piercings to be done in unregulated settings while incarcerated. That actually brings us to our next risk factor, which can be percutaneous or parenteral exposures in an unregulated settings, i.e. garage tattoos or piercings that are done outside of a professional shop. One important thing that I always like to tell my patients is they would tell me, well, I had a tattoo, but I saw the person change the needle in front of me. It's important to also tell them to change the ink as well, because hepatitis C can live outside of the body for about 72 hours or 3 days. And so I've had some instances where we can't think of anything else other than the potential of a unprofessional tattoo where they might not have changed the ink. So that is something to consider as well. And then one of the other major risk factors are men who have sex with men because of the blood exposure potential. So when we look at screening, how do we interpret it? Well, as of right now, the primary method for screening is to first start with a hepatitis C antibody. That hepatitis C antibody will either be non-reactive or reactive. If it's non-reactive, great. That indicates that you are not currently infected with hepatitis C, nor have you likely ever been infected with it. If your hepatitis C antibody is reactive, you need to do additional testing in the form of a viral load. So I said earlier that hepatitis C was a single-stranded RNA. So your viral load is detected based on the number of RNA copies that can be determined. If your RNA is not detected, but yet your hepatitis C antibody was positive, that means you're not currently infected, However, at one point in your life, you likely did have an infection and you either spontaneously cleared it or you were treated and then cleared it. If your viral load is detectable, that does indicate a current hepatitis C infection, and you should undergo treatment in most cases. Now, I said at the beginning of this slide that this is our current screening recommendations. Here in the United States, there's a big push to potentially get rid of the hepatitis C antibody requirement and just go straight toward the hepatitis C RNA to tell you whether you're actively infected or not. There's also bigger pushes to use point of care testing. So that way you can meet your patients where they are in the community setting, whether you have mobile clinics or whatever community engagement or outreach that you might do. So we've determined that you have hepatitis C. Now it's important to decide where can we treat them. Should they be treated in a community setting, primary care, an addiction med clinic, or should they be referred for specialized care? Truthfully, any adult 18 years of age or older who has chronic treatment naive hepatitis C of any genotype, whether it's 1 through 6, can be treated in a primary care or community based setting, assuming that they have little to no evidence of advanced liver disease determined by fibrotic staging of F2 or less. Now, technically, if you were to look at the AASLD IDSA guidance, it does say that community providers can treat up to compensated cirrhosis. However, in our professional opinion, we have recommended that F3 or F4 fibrosis be treated by a specialized provider because we want them to establish care. Because after treatment, even if you are a compensated cirrhotic post-treatment, you're still going to require that cirrhosis management. And even if you're a perfectly well-controlled cirrhotic, you're still going to require an annual EGD. You're going to require biannual imaging for hepatocellular carcinoma. You're going to require routine monitoring and assessment for ascites, as well as hepatic encephalopathy, in addition to blood work to follow your MELD score. So there's a lot of reasons why we want them to establish care. And as bad as it sounds, sometimes the hepatitis C can be that motivator, that carrot that gets them to come into the door. Now, it says treatment naive can be treated in primary care settings. It's important to note that treatment naive in this case is naive to our existing direct acting antivirals. So, historically, before the advent of our oral agents that we have nowadays, we use things like interferon or ribavirin. If you had a combination of interferon, ribavirin, or a combination thereof, that does not count as treatment experienced to our current regimen. So you can treat somebody who's had past interferon in the community setting, as long as they have not had treatment experience to a direct acting antiviral, which we'll talk about what those all are here in a few slides. Patients who should be referred for more specialized care include those who have been previously treated for hepatitis C with a direct acting antiviral. Again, our professional opinion is those with advanced fibrosis being F3 or 4 or greater. If you have HIV or hepatitis B co-infection, if you're pregnant and or breastfeeding mother, unfortunately right now we're unable to treat hepatitis C during pregnancy or breastfeeding just because of a lack of information. Now that being said, it's important to still have them established with a provider while pregnant or breastfeeding for their hepatitis C, as the workup can be done while pregnant, while they're most engaged in the healthcare setting. And then postpartum, or once they're done breastfeeding, you can pursue treatment then. Then if you have known or suspected hepatocellular carcinoma or a prior liver transplant, I think those two go without saying, but we should be following with a hepatologist ideally. So we had made mention just a little bit ago about the importance of assessing for fibrosis or cirrhosis. There are several different ways that you can assess for fibrosis. The gold standard remains to this day the liver biopsy. However, if we think about it, the liver biopsy is invasive. It can be a logistical nightmare because you require pre-admission testing, you require a potential admission for the biopsy. You also lend yourself to biases or interpretation differences depending on the person who's reading the exam. So even though it's technically the gold standard today, in practice, we predominantly use non-invasive measures for fibrosis. The first one that we start with is usually a FIB-4 score, which a FIB-4 score is a calculation that's based off of your age, your LFTs, and your platelet count. These are readily available in the community setting and are a great place to start. If you have a FIB-4 that's less than 1.45, you can say with 90% certainty that you do not have or likely do not have advanced fibrosis, being either F3 or F4. If it's a score anything greater than 1.45, it is recommended that you receive a second form of non-invasive fibrotic assessment. So what exactly are those other forms? Well, you can have transient elastography, which would be like a fiber scan or an ultrasound of the abdomen with elastography. You could also have non-invasive serologic tests, such as a FiberSure or a fiber test. Admittedly, they're a little less sensitive and accurate compared to a fiber scan or an ultrasound with elastography. Other pretreatment considerations should be a complete medication reconciliation to help identify any potential drug-drug interactions. We'll talk about those here in the near future about what those drug-drug interactions look like and what resources are available to detect them. We should also educate our patients regarding hepatitis C, along with the risks associated with not treating it, and look at risk factor management to prevent spread to others as well as reinfection once you are treated. Lastly, there are several labs that we'll get before we can initiate treatment. Anytime prior to initiating the antiviral, we should have a hepatitis C viral load. Most insurance plans do require that this hepatitis C viral load be done within 180 days or 6 months. We should also have an HIV antigen or antibody test along with hepatitis B surface antigen testing to rule out co-infections. And then in certain cases, a hepatitis C genotype is still recommended. So in most clinical scenarios, the genotype is not necessary anymore because we have pangenotypic medications. Now, that being said, for our non-Medicaid, so the Medicare or commercial plans, some of those insurers still require genotyping to be done. So it was always our policy that we would still get the genotype to avoid any delays in treatment down the road. Clinically speaking, though, one of the only times that it is necessary to get a hepatitis C genotype is if you have a compensated cirrhotic who you're wanting to treat with Epclusa. You'll need to do a genotype because if you're genotype 3, you'll have to do additional resistance testing. Additional labs that are a little bit more time sensitive include a CBC, a hepatic function panel, an EGFR, and then if you have any form of advanced fibrosis, we should be getting an INR to help calculate our MELD score. If you're a woman of childbearing age or childbearing potential, we should also be obtaining a serum pregnancy test as well. So in true Oprah Winfrey fashion, almost everybody should be treated. I won't say everyone. There are two populations that should not undergo treatment. The first population is if you have a short life expectancy of 12 months or less that cannot be remediated through hepatitis C resolution. And then lastly, if you're a liver transplant candidate. Liver transplant candidates, there's two main reasons why we won't pursue treatment in this population. One is if you're a liver transplant candidate, treating your hepatitis C will actually decrease the transplant pool that you can take from because you're no longer able to then take from a hepatitis C infected liver. The other reason is through the transplant process, the majority of patients will spontaneously clear their hepatitis C. Liver transplant candidates, when we think about them, are those that have a history of hepatocellular carcinoma, those with significant decompensated cirrhosis, and these patients should ideally be following with a hepatologist as well or a gastroenterologist. Outside of that, though, like I said, Oprah Winfrey, treat everyone. So how do we treat them? Today, we use direct-acting antivirals or DAAs. These work through action during the translation step, like we talked about earlier. So hepatitis C is a single-stranded RNA virus that through the translation process results in structural and non-structural proteins. Those non-structural proteins will go on to form your viral replication complex. There are several of these non-structural proteins that then serve as your drug targets to essentially prevent the virus from replicating and making more of itself, while providing time for your liver to get rid of the existing virus. The nomenclature for these non-structural proteins may seem daunting at first, but there is absolutely a way to help remember them. I think it's also important to note that when I was in pharmacy school, we always just did everything through memorization. We learned NS5, NS5B, A, NS3 or 4. NS simply stands for non-structural, and then the number associated with them is that specific non-structural protein. So if we look, your NS3/4 protease inhibitors, P for protease, so all of them end in Previr. Our most commonly encountered protease inhibitor is going to be glecaprevir, as it's used in combination with pibrentasvir for Mavorit. You'll also see voxlaprovir used within the combination product called Vosevi. However, that is typically reserved for patients who have failed a prior direct-acting antiviral. Your NS5A inhibitors, also A for Asvir. So you have ledipasvir, which is used in combination for Harvoni, which was one of the original or one of the earlier direct-acting antivirals. You'll more commonly see, though, the pibrentasvir, the velpatasvir used within the Mavorit and Epclusa combinations, respectively. Then you have an NS5B inhibitors. All of these B ends in buvir, so sofosbuvir being in combination within Epclusa. I also included purine nucleoside analogs such as ribavirin, as in the community setting, you won't necessarily encounter ribavirin. However, ribavirin still has a place in therapy for hepatitis C if we have a patient with decompensation, or if you get really into your bag of tricks for those with past failures. I did highlight, though, in red the two most commonly encountered ones within practice, those being Mavorit and Epclusa. As a past pharmacist within the hepatology space, I would also use Vosevi and ribavirin. I admittedly have not had to use any of the others throughout any of the patients that I treated before, just the Mavorit, Epclusa, Vosevi, and ribavirin. So when we look at those two that we'll typically encounter within the community setting, it's important to compare and contrast. So we already said Mavorit has that protease inhibitor, whereas Epclusa does not. Both of these medications are pan-genotypic. Both of these medications can be used in patients with or without cirrhosis. However, Mavorit can only be used in patients with compensated cirrhosis. It is contraindicated for decompensated cirrhotics because of the protease inhibitor component. Epclusa can be used in compensated or decompensated. Mavorit is dosed as 300-120 milligrams once daily with food. However, it's important to note, in order to be able to get the dosing correct, you do need to take 3 tablets once a day. I'll get a lot of questions, or I did get a lot of questions about the food component. There is no specific calorie count associated with it, no specific fat content associated with it. If you actually look at the trials that led to its approval, it was looked at with as small as a couple saltine crackers. So it doesn't have to be anything astronomical. It just needs to be enough for your gastric juices to get flowing.
Kenny,
The nice thing about, oh,
we
go
have a
ahead.
question
Yeah.
from Dr. Delis Reyes. Why combine the different drugs? Does that improve efficacy?
Yeah, so it absolutely does. If we look back here, one of the first medications that was used was sofosbuvir or Sovaldi by itself. It was found by having multiple mechanisms of action and multiple drug targets on those non-structural proteins. It resulted in higher cure rates, or the SVR12 rates. And that's true again whenever you get into somebody who's failed treatment. You'll notice that Vosevi is one of the options. Vosevi is a 3-drug combination that includes a 5A, 5B, and protease inhibitor. So it holds true as you progress throughout treatment that if you do fail, we'll look to add another agent through another mechanism to target it. But absolutely great question. Um, Now, where we left off with the Maverick, it does have a shorter duration of a total of 8 weeks, whereas the Epclusa is a little bit longer of a duration. So when we compare and contrast them, Epclusa is 400 100 milligrams once a day. This is available as a single tablet. So your actual pill burden with Epclusa, while your treatment is longer for a total of 12 weeks, the pill burden itself tends to be less with Epclusa because it's one a day versus three a day. Epclusa can also be taken with or without food. I just recommend for patients that they keep it fairly consistent. If you're going to take it with food, always do it with food. If you're not going to do it with food, don't do it with food. Um, there are no renal considerations regardless of the medication that you go with. And the only hepatic considerations surround Mavorit, again, if you have somebody with a history of hepatic decompensation, especially if their child Q class B or C. So when I think about this and I'm considering what options to use for a patient, I'll typically see what's more important to them. Is it pill burden or is it duration? I've had some patients who they're now sober, and the last thing tying them to their past addictions is their hepatitis C. So they want to get treated as quickly as possible. So in them, I'll go with the shorter duration Mavorit. I have others that simply want to have fewer pills. So if it's a pill burden issue, I'll go with Epclusa. I also will discuss their food scarcities or access to food because if they have any scarcities or if they have limited access to food, Maverick probably isn't the best opportunity for them. So I had several of my patients who would go to food kitchens or shelters, and they would have limited access to food on a routine basis. So in those cases, I would likely go with Epclusa. Um, Other considerations is I had some homeless patients. One that comes to mind is he was a type 2 diabetic who was insulin dependent. And he carried all of his things, including his insulin, in a single cooler that he could wheel around. If he couldn't fit it in his cooler or he couldn't fit it in his jacket or pockets, he wasn't able to take it with him. When we look at how the medications are supplied, Epclusa is either supplied in a small pill bottle of 28 tablets, or it's in small compliance packaging where it's one box about yay big, that has a whole month's worth in it. Maverick, on the other hand, is supplied in four individual compliance packaging boxes, one box for each week. And that single box is bigger than the single box of Epclusa, plus you have four of them. So for him, I went with Epclusa simply because it was easier for him to store. Those are some of the considerations that we should be having and some of the conversations that we should have with our patients. So when we look at the primary literature that surrounds these two medications, the glecaprevir, pibrentasvir, and Mavorit was studied through three different trial series. There was the Surveyor, Expedition, and Endurance trial series. You can see off onto the far right, the primary outcome was the same for each of them. You're looking at SVR12. SVR12 is simply sustained virologic response 12 weeks after you finish a medication. That is essentially our cure. What you're going to do is you're going to repeat your hepatitis C viral load 12 weeks after you finish the medication. If it's not detectable at that point, great. It appears that you achieved a cure. If it's still detectable, unfortunately, that means that you likely did not achieve a cure and you have to look at other treatment opportunities. Again, those that have failed treatment should be referred for specialized care. You can see in each of the three trials that were selected here, Surveyor 1, 2, and Expedition 1 had extremely high SVR12 rates, where it was typically 97 or 96% or higher. The one caveat is in the Surveyor 2, where it looked at genotype 3, you did have a reduced SVR12 rate of 83 to 94%. It's important to note that genotype 3 is the most rapidly progressing one in terms of fibrotic potential. It's also the most rapidly replicating, so it can be a little bit more difficult to treat. Our pan-genotypic medications do fairly well. However, in the earlier days of hepatitis C treatment, our non-pan-genotypic agents generally would not cover genotype 3. That tended to be the more difficult one. Similarly, sofosbuvir, velpatasvir, or Epclusa was studied through a single trial series called the Astral trial series. I included Astral 1 through 3 on this page here. Again, you can look over at the primary outcomes, which again were SVR 12. You can see that the overall cure rates were extremely high with this medication, 99% in most cases. Astral 3 did see a slight decrease in overall success rate of about 95%. Again, this was in genotype 3 patients. The reason that there's so many trial series associated with these medications is before the advent of Mavyret or Epclusa, you had non-pangenotypic drugs. So each of these trial series are looking at individual genotypes. They're also looking at patients who might have compensated versus decompensated cirrhosis. They're also looking at patients who may be co-infected with HIV or hepatitis B. I think if you look at it now, the Astral trial series is up to 14 or more trials at this point. So there are several of them associated with it. So after you've picked a medication, or I guess one thing that should go into your medication selection is drug-drug interactions. Now, we don't have the potential to go over every possible drug-drug interaction. So I wanted to make sure that we left you with the resources necessary to investigate those potential interactions. One of the best tools that I've found throughout my time as a treater was the University of Liverpool's Hep Drug Interactions. This is a free tool that you can use. Liverpool has this available for hepatitis B, hepatitis C, and then also for HIV. You can similarly use the AASLD's, IDSA's Hep C guidance. There's a section called monitoring patients who are starting Hep C treatment, are on treatment, or have completed therapy. This section of the guidelines will break it up into a table format of red being an absolute contraindication, green being okay to use concurrently, and then yellow being something that might require a medication adjustment. If you have a co-infected patient with hepatitis C and HIV, there is the AETC program, which is the AIDS Education and Training Center, which will help you select a hepatitis C treatment based on the HIV medication that's currently being used. And then if you can't find what you're looking for through any of those three resources, you can use tertiary databases such as Lexicomp. Now, the drug-drug interactions that you'll most commonly encounter, at least what I did in my practice, was typically antipsychotics, anticonvulsants, antacids, and then statin medications. Those tended to be some of the more common ones that I would encounter. What's really nice about a lot of these tools, especially the University of Liverpool, is they'll give the rationale behind the interaction, and they'll actually give a recommendation for how to navigate it. Is it something that we should completely avoid, or what are the changes that we can make? One of the nice things about the medications we have nowadays are they're extremely well tolerated. The most common adverse drug events are fatigue, GI intolerances, including nausea, vomiting, and diarrhea, along with headaches. Prior to this, when we had interferon, it was very poorly tolerated. You had a lot of flu-like symptoms, and only about half of the patients actually finished treatment because of the significant adverse drug events. Couple that with only about half of the patients who received interferon actually achieved a cure, we've made significant strides moving away from that time over the last 10 to 20 years. One thing that I like to point out, although it's not common, I still bolded it, is the potential for hepatitis B reactivation. So with these medications, it's important that you're assessing for hepatitis B before you initiate treatment. If you're co-infected with hepatitis B, you'll undergo Hep B treatment first before you start your hepatitis C treatment. Your Hep B treatment will then be continued during the course of hepatitis C treatment and potentially for a little bit after. The reason for that is hepatitis C treatment can cause your hepatitis B to become fulminant. So it's important that you establish on hepatitis B treatment before initiating Hep C treatment. Now, that being said, our office would do a complete workup for hepatitis B, including hepatitis B surface antigen, core total antibody, and a surface antibody. If there core total antibody was positive along with their surface antibody, that was a good indicator that they had a past hepatitis B infection. However, their surface antigen being negative meant that they were not actively infected, just a past one. In those cases, we did not initiate hepatitis B prophylaxis as they are already surface antibody positive and the likelihood of reactivation is low. So it's not necessary to prophylax beforehand. Other adverse drug events outside of the more common ones include altered mood, asthenia, and then you can have skin rash or irritation. Typically looks like a more common allergic reaction than a true adverse drug event. So the bottom line is in the community setting, in the addiction medicine space, we can absolutely treat patients with acute, chronic, treatment naive hepatitis C who do not have advanced fibrosis. We should ideally be screening patients for hepatitis B and HIV before initiating treatment. And then there's been a significant evolution in our treatments for hepatitis C. They're now pan-genotypic. They're all orally available, shorter durations of 8 to 12 weeks. If we look back at the old interferon days, these were typically for a year or more. You now have high SVR12 rates of about 98% in most cases, recognizing that you can have certain factors that decrease your success rate. Things that can decrease your success rate with treatment are advanced fibrosis or cirrhosis, if you have heavy alcohol use alongside it, if you have any other reason for potential liver damage or disease, those can possibly decrease it. If you have genotype 3, that can decrease it as well. But in the majority of patients that we're treating in a community setting, you have about a 98% success rate. Your adverse drug events are fairly minimal, and the medications themselves are well tolerated, especially in comparison to past treatments. I will say this is a point that you'll have to make with a lot of your patients, especially those who have been chronically infected for a while, who might have undergone interferon and ribavirin treatments in the past, or who have known friends or family to undergo it. I had to dispel a lot of concerns or rumors surrounding the new medications because of the past experiences that people had with prior treatments. So in terms of how we actually get the medication, so this is all well and good, but how do we actually get it into our patients' hands? Well, these medications are all considered specialty drugs and they have to come from a specialty pharmacy. Even though your treatments are anywhere from 8 to 12 weeks in most cases, unfortunately, insurance companies are typically only allowing you to dispense 28 days or 4 weeks at a time. Now, there are lobbyists that are pushing for the full amount to be able to be dispensed to patients to help avoid the need to re-engage them for refills. For the drug acquisition, most insurance plans will still require prior authorization, especially if you're Medicare or a commercial plan. Here in the state of Ohio, there's currently lobbyists that are pushing for the removal of PA requirements for Ohio Medicaid. You may also require peer-to-peer reviews and or appeals. When I've had to do these peer-to-peer reviews or appeals, they've typically been for commercial plans. I have not had many issues with Medicare, Medicaid, or dual eligible folks. When it comes to the modalities for your PAs, this can either be electronic, verbal, or fax. Now, once it's approved, you may have patients that have higher copays. It's important to recognize which type of insurance plan they have because this can lead you to which assistance paths to go. If you have Medicaid only, or if you're a Medicare, Medicaid dual eligible patient, you don't really need to worry about this as they should be fully covered by those insurance plans. If you have a commercial insurance through an employer, you'll likely be left with a high copay. However, you are able to qualify for manufacturer-sponsored copay cards. If you go on Google, type in Epclusa copay card, go on, type in Maverick copay card, it'll be the first thing that comes up. It takes a couple minutes to apply for it, and then it brings the cost of the medication down to about $5 to $10 or less a month. The patient population that's a little bit more convoluted to navigate is the Medicare population. There are two options listed. However, this manufacturer-sponsored patient assistance program in most cases is no longer applicable for them. In most cases, for Medicare patients, you'll have to pursue national grant funds, which can be through things like the HealthWell Foundation, PAN Foundation, or Patient Advocate or Assist. Where those manufacturer sponsored patient assistance programs now come in, however, is for our uninsured patients. So if you are uninsured, you can apply for things like AbbVie's patient access support, AbbVie being the manufacturer of Mavorite, or Gilead's support path program, Gilead being the manufacturer of Epclusa. This also works for our patients who are undocumented immigrants. I've had several who were originally from Mexico. They did not have a social security number, so they were not able to apply for Medicaid or have commercial insurance or marketplace insurance. In those cases, even if it was an undocumented immigrant, I was able to use the manufacturer sponsored patient assistance programs.
Kenny, another question from Dr. Dallas Reyes. Do you know if insurance or clinic policies still require a 3 to 6 month sobriety or abstinence? Has that been taken away?
Yeah, that's a great question. I have only encountered it with a couple commercial plans. Medicare and Medicaid does not require it because the guidelines have changed, and most of the insurance plans have adopted the changes. After the study that was released that showed if you have continued IV drug misuse within the first 3 years of your diagnosis and continued use, you'll infect on average 20 other people. After that study came out, it really called for the importance of still treating them regardless of their degree of sobriety, because at least then you're reducing the risk of infecting others. So the majority of insurance plans have adopted what the guidelines have said. The one caveat is certain commercial plans I've had that I can think of three instances out of the like 450 to 500 patients that we treated where we had to write a letter saying, and the patient had to sign it, saying that they've been sober in terms of drugs or alcohol for the last 6 months. But outside of that, Medicare, Medicaid, absolutely not. And majority of the commercial plans still no. Great question, though. So, whenever you're actually on treatment, what type of monitoring needs to be done? Well, previously, there was a lot of on treatment monitoring that needed to be done because of how many adverse drug events were associated with things like ribavirin and with interferon. Now, fortunately, because of how safe and effective the medications are, there's really no on treatment monitoring that's necessary for most patients. Now, that being said, if you have a history of diabetes or you have therapeutic anticoagulation with warfarin where you're monitoring an INR, it is important to follow them a little bit closer. The reason behind this is whenever you undergo treatment for hepatitis C is you'll typically see an improvement in your overall hepatic function. That hepatic function improvement may result in improved insulin sensitivity. It will also result in an improvement of your activation of your clotting factors or coagulation cascade, which can result in symptomatic hypoglycemia or subtherapeutic INRs, respectively. So, for these patients, especially if you have a patient with diabetes who's also on insulin secretagogues, or sulfonylureas, it is important to mention to them the risk of hypoglycemia and making sure that they assess their home blood sugars a little bit closer. So, in a traditional patient, what we would do is we would have the initial visit with myself where we would go over all of the education, we would review their past lab work. We would also then educate on the medication that we would pick. You would then initiate treatment, and then 12 weeks after they're assumed to be done with the medication, we would hold a follow up visit to get repeat blood work, most notably being a hepatitis C viral load to see if their virus had cleared or not. We do not, if you look at the way that the studies were done and the way that previously had been treated, they used to bring patients in every 4 weeks to get a repeat hepatitis C viral load. However, that's kind of gone out of favor with these new direct acting antivirals. Obviously, that being said, depending on yours and the patient's preference, you can follow up a little bit sooner if necessary. Now, inevitably, patients are going to miss their medications. I know I miss my medications and I'm a pharmacist. So inevitably, patients will miss their medications. It doesn't, the most important thing to note is at what point in their treatment did they miss? Is it the first 28 days of therapy or is it after the first 28 days of therapy? The next most important thing to note is, well, how many consecutive doses have they missed? So we'll start off on the left-hand side. If you miss a medication within the first 28 days and you miss 7 or fewer consecutive doses, you can restart that direct-acting antiviral immediately and finish out your treatment duration like normal, the 8 to 12 weeks. This, again, is regardless of whether that's Mavyret or Epclusa. Now, if you miss 8 or more consecutive doses, what you'll do is you'll restart the medication and then you'll collect a Hep C viral load. If your hepatitis C viral load is negative or undetectable, you'll complete the original planned 8 to 12 week course of treatment. The reason that they mention if it's negative is because if you look at the pharmacokinetic studies surrounding these medications, the majority of patients with Mavyret, and the majority is about 94% of patients will achieve a cure with Mavyret at about the 4 week mark and will achieve a cure at about the 6 week mark with Epclusa. So it is not uncommon for patients to be able to achieve a cure without having completed the entire regimen. So there is a potential that it could be negative already within that first 28-day period. If that's the case, you'll still finish out the remaining course of treatment. If your hepatitis C RNA is positive at that point, you'll want to extend out the treatment for an additional 4 weeks. If you flip over to the right-hand side, if an interruption happened after the first 28 days and you miss 7 or fewer consecutive doses, you'll restart the medication immediately and then continue as planned for the 8 to 12 weeks. So really here you can see on both cases, you do have about a 7-day buffer where as long as you don't miss consecutively for that 7-day period, you'll finish out the course as planned. Now at the bottom there, you'll see if they've missed 21 or more consecutive days, you'll just stop the medication and you'll repeat their hepatitis C viral load 12 weeks after their last dose was given to see if they've cleared it or not. I had one patient who, to just show the potency of these medications, I had one patient who experienced a rash on the back of her neck and the top part of her scalp, and it was concerning to her to the point that she stopped taking the medication. She was prescribed a 12-week course of Epclusa and she finished just under half of the medication. I think it was 41 total doses. And she was able to actually clear the virus. So it is not uncommon for patients to be able to clear it with partial courses. There was
Okay,
actually a
we're
trial
getting
called the Simplify trial that demonstrated that as well. That Simplify trial looked at medication, specifically Epclusa, to see adherence rates and overall cure rates, and it found that there was plenty of wiggle room in terms of adherence.
Kenny, we're getting down to the last few minutes, and we want to save some time for a couple questions or some conversation about this. So just give you a heads up.
Absolutely. I think I only have about 3 more slides here, and then a patient case at the end. Actually, yeah, because this is the follow-up. So the follow-up for these patients is divided into those that have cirrhosis versus do not have cirrhosis. If you're a non-cirrhotic patient and you've achieved your cure, which is no hepatitis C RNA detected 12 weeks after the medication, great. You can go back to following with your PCP like normal. Again, management of risk factors is important. And then if you have IV drug misuse, annually screening for hepatitis C, men who have sex with men, annually screening for it. Otherwise, it's all risk factor driven. If you're cirrhotic, you will have to follow closely with a hepatologist or gastroenterologist. Post treatment, you can see all of the reasons for that listed here on the screen. So with that, I did have a brief patient case just to get your guys' thoughts. And then after this patient case, we'll open it up for questions. So RMT is a 49-year-old white female with a past medical history significant for chronic hepatitis C. They have a history of IV drug misuse with sobriety over the last 18 months and bipolar disorder. The patient presents for treatment of her chronic hepatitis C. She says that she's never undergone treatment and is naive, and the following labs were collected in the past 2 weeks. Her hepatitis C viral load was admittedly high. Anything above 800,000 is considered a high viral load. So she had 4.2 million copies. She was negative for HIV or hepatitis B, so no co-infections. Her LFTs were listed there for you. Her EGFR was normal, and her platelet count is also listed for you. We did not do a pregnancy test because she denied male partners. She only has one partner, and it is a female, so there was not a potential risk of pregnancy. So the first two questions are: is RMT able to be safely treated in the primary care setting? And if she is, what medications, doses, or durations would you select and why? So let me open up the chat here and see.
Well, here, if we could go back to the full screen. I know that Dr. Marsh is saying it would be good to talk on some interactions with some new or unusual medications.
Yeah, so
Here,
interactions that,
could we go back to the full screen? We only have about 3 minutes left here.
Yeah. I think that's if you just stop sharing.
okay, there we go.
So, Sybil, you had a question?
Oh no, mine was just a kind of a reply